Good afternoon, everyone. I'm going to give a second for my screen to share. There we go. Good afternoon, and welcome to today's presentation, the nuts and bolts of MIPS scoring and quality measures. This is part one of a three-part series, and you will receive more information about the second part and third part at the end of today's webinar, and those dates are also included in your invite to today's webinar. My name is Kaylin Henderson, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout the presentation, so please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will be interactive polling questions, and in addition to our presenter has provided a few resources and a copy of today's slide deck, you'll find these resources noted as handouts included in your taskbar as well. Today's presentation will be recorded and later uploaded to our Health Visions Delmarva PTN YouTube channel. We ask everyone to visit this channel simply by going to YouTube and searching Health Visions Delmarva PTN. You can also subscribe to this channel and even get post notifications as we upload more content. We are fortunate to have our very own Cindy Eisman, EMBA Project Manager for Health Visions Delmarva, joining us today. Cindy Eisman, EMBA, is a Project Manager for Health Visions Delmarva, a practice transformation network working through CMS Transforming Clinical Practice Initiative. Cindy has over 30 years of experience in healthcare, starting in the area of health information management and expanding her skills in areas of expertise to performance improvement, operations management, healthcare financing, and practice transformation. Cindy has been a CEO, COO, and quality and operations director with HealthSouth, Kindred, and several community hospitals. Cindy is a native of Pittsburgh, a graduate of the University of Pittsburgh and the Troy University in Alabama. Cindy, I would now like to transfer this over to you so you can begin today's presentation.
Okay, Caitlin, thank you. Give it a second. Show my screen. And I am looking for this clean screen. There we go. All right, hopefully everybody is now seeing the learning objectives screen. I want to thank you all for joining us today. We have a lot of content to cover, so I want to launch right into it. Our learning objectives for today are to understand the quality measures that are part of the MIPS system, to understand how those measures are scored and how this is going to impact your total MIPS score. And we want you to be able to pick the most appropriate measures for your practice when we're done with this session. So given that, our agenda will be as follows. We're going to do a brief overview of the full MIPS scoring components and eligibility, just so we're all on the same playing field. We're going to look at the MIPS quality measures specifically today and go through what those are. We're going to look at the measure submission methods and how you're going to actually turn this data in, and then kind of go through some recommendations on how you can pick the best measures for your practice. As we go through the presentation today, I would like to have you think about a couple of questions that we call our questions to run on. These are things that if you think about them while we're going through the presentation, hopefully by the end, these are the things that we'll address in your mind and what we'd like you to be thinking about. So first of all, how can I use MIPS quality measures to reflect the great work I am doing with my patients? You know, we want to demonstrate the high quality that our practices are providing in patient care. A second question would be, how can I use MIPS quality measures to further improve the clinical outcomes of my patients? So we never want to settle for where we're at right now. We want to always make sure that we are getting a little bit better. And so how can I use MIPS measures to do that? And then what tools do I have available to me to make an informed decision about which quality measures are best for my practice? And hopefully by the end, you will be able to see that there are tools available to you in addition to the advice of your practice advisor to make the right decisions for your practice. So here we're going to launch our first polling question. So Kaylin, if you want to launch that.
Sure. Our first polling question today is, how well do you believe you know QPP MIPS system? You have an option for confident and ready to participate, knowledgeable but have some outstanding questions, limited knowledge and need some help information, or just starting out and this is your first initial education. I'll give it just a second as the polls seem to still come in. All right, I think we're pretty steady. Oh, nope, still changing. Okay, I'm going to go ahead and close that there. And I'll go ahead and share those results. Cindy, we had about 24% confident and ready to participate, 38% knowledgeable but have some outstanding questions, 29% limited knowledge and need some help, and 9% starting out and that this is their first education. I'm going to hide that, share your screen again.
Okay, well, that's good for me to know. So I know a little bit of how much to spend on each section. It looks like we have quite a few people who are confident and or knowledgeable and are feeling like they're ready to move forward, and a few that we're going to start out with, and this is going to be your first education. For those of you who this is your first education, there are additional resources and webinars available that I'm going to recommend that you look at that give you a lot broader overview. But for right now, let's go over kind of the basics, the things that are absolutely necessary for us to know for this session today. So first of all, who is included in MIPS in 2017? Well, the following clinicians are included in this program this year. Physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. The slide shows you the definition of a physician, so which types of clinicians are considered a physician under the MIPS system. I will note that if you have, when you're looking at how you're going to report your data, if you have nurse practitioners that bill under your TIN and their own NPI, so they bill their own services under their own NPI, you have to report data for them. And if you're reporting individually, you'd have to report separate data for them. If you're reporting as a group, their data obviously is going to be just included in your group, and so will the data of any nurse practitioners billing under the auspices of a physician. Then we get questions a lot about, what about non-patient facing clinicians? Well, what does that mean? Well, a non-patient facing clinician is an individual that has less than 100 patient facing encounters during a performance period. An example of a non-patient facing clinician, kind of the classic example, might be a pathologist who is behind the scenes interpreting test results. They're interpreting biopsy results, but they're not seeing the patient. They don't have patient-facing encounters. They still bill their services as a Part B billing code, but they're not actually seeing the patients, so they're not considered patient-facing. A group would be considered non-patient-facing if more than 75% of the NPIs that bill under their TIN during that performance period are non-patient facing. So a group of pathologists, a group of potentially radiologists, diagnostic radiologists. Non-patient facing clinicians are MIPS eligible, but there's different flexibility in the reporting requirements. So there are some things that you will need to report, but not everything is going to apply to a non-patient facing clinician. So if we are working with you and you are a non-patient facing clinician, we will work out the specifics of that flexibility and those differences. So then who is not included in MIPS? If you've newly enrolled in Medicare this year, this 2017 is the performance year we're talking about, you do not have to report for MIPS. You're not going to be subject to any penalties or adjustments, but you will in 2018. Clinicians who are below a low volume threshold. So if you bill less than $30,000 a year in Medicare Part B charges, or, so this isn't an and, it's an or you see less than 100 Medicare Part B patients in a year, you aren't eligible and not included in MIPS. And that means that you will not have a payment adjustment, negative or positive, but you also won't have to comply with the reporting requirements in order to avoid a penalty. So this was a change from the original rule. they upped the amount to $30,000 and they made it an or, not an and. So if either of those things apply to you as a solo, it would be a solo practitioner in a very small practice with very few Medicare Part B patients, you would not be subject to the MIPS system. And then finally, if you qualify in an advanced alternative payment model, and that would mean that you are participating at least partially in some Medicare advanced payment model, maybe an MSSP ACO Tier 3, not a Tier 1 or Tier 2, but a Tier 3. And at least 25% of your Medicare payments are coming through that ACO, or 20% of the patients you see are coming through that ACO, you would actually be exempted from MIPS because the reporting that you're doing is through the ACO or that advanced APM is going to serve for your reporting for the Medicare program. So what is MIPS? It's a new payment system. It does streamline 3 legacy programs that have been in effect with CMS, and those would be PQRS, Meaningful Use, and the Value-Based Modifier Program. It adds a 4th component of improvement activities that are seeking to promote improvement and innovation in the clinical activities in our practices. MIPS allows clinicians flexibility to choose measures and activities that are most meaningful to their practices. I forgot. I should have hit those while I was saying the word. MIPS in 2017. A MIPS score is calculated by adding together these 3 performance categories. So if you remember on the previous slide, I told you there were 4 categories, but resource use is not going to be included in this first year. So in 2017, 3 categories are going to be scored: quality, improvement activities, and advancing care information. You'll get individual scores in each category. They will all add up to your final MIPS score. The cost category will be included in 2018, so it's something we want to keep our eye on, but it's not something that will be included in this score. And if you don't report any data in a particular category, you score 0 for that category. So that doesn't mean you get no MIPS score. It just means your score will be lower because you won't have points from all of the available categories. The categories are weighted. Weights are assigned based on a 100-point scale. So quality is worth 60% or 60 points on a 100-point scale. Improvement activities are worth 15% or 15 points on that 100-point scale. And then advancing care information is worth 25 points. These are default weights. If there are certain circumstances where you would not report advancing care information, in some cases that might be for those non-patient-facing clinicians, or if you apply for an exception, which we will talk about in a future seminar, webinar. But if you do have exemption from one of the categories, the weights will be reweighted and most likely to the quality measures category. So in 2017, because this is new to everybody, there's an expectation that there's going to be some challenges in reporting information. And CMS has offered to try to make this something that we all can manage under, though, and prevent people from having any negative impact in their reimbursement. So they've introduced a pick-your-pace participation model. The first thing that you could elect to do is what's called the test pace. And in the test pace, you just have to submit something, anything. One data measure for quality on one patient will do it for you. If you submit something, if you at least try, is how we say it. If you at least try, you will be guaranteed at least a neutral payment adjustment, that is no payment adjustment to your fee schedule, or a small positive payment adjustment, depending on how much you do submit. There's really, therefore, no excuse for non-participation in 2017. So you want to pick something that will help you test your pace, and we'll talk about the easiest way to do that in a minute. You could submit a partial year of data. If you submit at least 90 days worth of data, you could get a small positive payment adjustment. The entire bucket for the performance year of 2017 that will be applied to payments in 2019 is basically plus or minus 4%. So all adjustments are small. It would be less than 4% likely if you are reporting only a partial year of data. And then if you submit a full year of data, you could expect a modest positive payment adjustment as long as you perform well to the benchmarks So non-participation in the quality payment program will result in a negative 4% payment adjustment in 2019. If you simply pick one of these methods, testing your pace, submitting something, partial year or full year, you will avoid that negative 4% payment adjustment. So let's talk just a little bit more about testing your pace and submitting something. This helps you to avoid that 4% penalty, and you just have to submit a very minimum amount of data. That minimum amount of data needs to be only one of these. You see that's or in between those. You either have to report one quality measure on one patient, or you have to attest to one improvement activity, or you have to report 5, depending on your practice size, base advancing care information measures, the base measures. For most of you on the line, because most of you are members of our Practice Transformation Network, you qualify for one improvement activity by being a participant in the Practice Transformation Network. That is an accepted improvement activity under the MIPS system. So your participation with the Practice Transformation Network, with your practice advisor to continue to work on your assessment, any gaps identified, and any performance improvement projects allows you to attest to that participation, and therefore allows you to qualify under the test pace category. Partial and full year reporting. Now, while it's nice that participating with us does let you get past the test phase, and it's a security blanket for anybody should you need it, we're strongly recommending partial or full year reporting to our practices. That's why we're working together to help you find the best measures and change what we need to change and address what we need to address to ensure you have very positive performance on those measures, because that's where you have the most opportunity for a positive payment adjustment. Measures can be reported for a period of 90 days up to 365 days. While we need to be planning now and understanding now what we're going to report, you're not going to actually report the data until the first quarter of next year. So there's time to determine whether you're going to report 90 days worth of data or 365 days worth of data, but we need to know now what your measures are so that we can ensure that we're doing things concurrently to ensure your best performance on those measures. The best way to earn the largest positive payment adjustment is to submit data on all MIPS categories. So not just the quality measures, but attesting to performance improvement activities and attesting to advancing care information is the best way to get the highest positive payment adjustment. And positive payment adjustments up to 4% for the 2017 performance year, 2019 payment year, are based on performance rates, not the amount of information or the length of reporting. So even if you do a 90-day reporting, but you have very good performance to benchmark, you can get a reasonable payment adjustment to the positive side. You also will need to select individual or group reporting, and this is going to vary based on your practice and how your practice performs and how your individual members feel about this. Practices have to decide if they're going to go individual or as a group. It doesn't matter if you bill as a group. Just because you bill multiple NPIs under your TIN, that doesn't force you to report as a group. You could still report based on those individual NPIs, because basically an individual is defined as an NPI number and the corresponding TIN they bill under. So all MIPS categories have to be reported the same way, however. So you need to talk with your group and identify which way is the best way to report. Do we want to report everything as individuals, or do we want to report everything as a group? There are pros and cons to each of those. If you have let's say you had 15 clinicians and you have really solid performance on your measures for 13, and 2 of them, maybe they're newer clinicians and they're just getting up to speed, aren't quite as good. Reporting as a group might be a good thing for you, because the high scores of your high-scoring 13 clinicians are going to mitigate somewhat the lower scores of the 2 lower-scoring clinicians. What if you have a group of only 4 providers and 2 of them do great and 2 of them don't do great at all? adding them together and averaging the results, if you will, might bring down your score significantly, and then that's going to apply to everybody in your 10. You may want to report individually so that you are limiting the impact of a poor score to a single individual as opposed to spreading that impact across your practice. There's really no way for us to tell you which way is the best to do it. You really need to pick your measures, look at performance, and determine what's the better way for me to report this. How does my scoring come out better? So it's going to be an individual decision. I will note that if a practice is in an ACO, you can only report as a group. It's the only way to report quality measures, and you're going to report them as the ACO measures anyway, so they're all reported as a group. Okay, so this is time for our next polling question. With that bit of background, Kaylin, you want to launch the second question?
Absolutely. Our next polling question is, which pace will your practice choose? Option 1 is that test, where you're going to submit some data and can result in a neutral adjustment. Second option is partial year, which is 90 days of data and can result in a small adjustment. We have the full year all data, which will provide a modest adjustment. And the last one is that you do not plan to participate and will receive a negative 4% adjustment. Of course, I hope no one picks the last one. Pretty solid on this right here. And actually, Cindy, I'm going to go ahead and close this and I'll share the results because I think I'll be extremely pleased. We do have 3% saying they're going to test some data. We have 37% for a partial year of the 90-day option, and 61% are going to fulfill that full year all data. So that's pretty exciting.
I am so proud of my PTN members. Great job, guys. I'm glad that we are setting bold aims for ourselves and aiming high. And I am sure that if we continue working together, we're going to be very successful with that. So now the kind of really the nuts and bolts. Here's the quality category. The quality category in 2017 reporting is worth 60% of your MIPS score. It totally replaces PQRS reporting completely. We select 6 measures. One of them has to be an outcome or high priority measure, and we'll talk about how you know that. With the exception of CAPS, so if you elect to report CAPS, that patient satisfaction information, you must submit all measures using the same method. And I'll repeat that, and that's why it's in bold. All your measures have to be submitted the same way. So it's really important as we're looking through measures and trying to decide which ones to report that we're aware of what type of measure they are so that we're picking all from the same type of reporting. There are 271 quality measures available, and these are the different submission methods that you could use. You could submit your data through claims, but only 74 of those 271 measures can be reported through claims. You can submit them directly through your EHR in a direct feed, but only 53 measures are available for submitting that way. You could use a registry. 243 measures are available to be reported through registry, so clearly the largest. And in fairness, you need to know how your measures are being reported, because some of you may be using an EHR and saying, well, my EHR does it. A lot of times EHRs are taking the data from your EHR, putting into a registry and reporting it through the registry. So it's important for you to ask that question from your EHR vendor if you don't already know. The CMS web interface only has 15 measures available, and that's a group-based web interface. That's the GPRO system. And then the CAP survey only has the one measure. It's about satisfaction, and that's the one that is excluded from same method reporting. So you could report 5 EHR measures and then the one CAPS for your 6. So quickly, another polling question. Kaylin? Oh, there's 2, in fact. I can't hear you, Kaylin, if you're talking.
I am so sorry. I was still muted. The first one is, did you participate in PQRS quality reporting last year? Option is yes, I reviewed my QRUR report, positive adjustment. Yes, I reviewed my QRUR report, QRUR report, negative adjustment. Yes, I did not, but I did not review my QRUR report. Or no, I did not participate. And it looks like we have some pretty solid polling here. So I'm going to close that and I'll share this. Cindy, we have 58% that said yes, they reviewed the QRUR report with a positive adjustment. 3% reviewed QRUR report with a negative adjustment. 27% did, but they did not review the QRUR report, and 12% did not participate.
Okay. So do the next question, and then we'll talk about those results.
This one is just, have you selected your MIPS quality measures for 2017? Simple yes or no, obviously. Some people are clicking yes, no, no, yes. I think we're pretty solid right here. So I'm going to go ahead and share that.
Okay.
Cindy, we had 70% say yes and 30% said no.
Wow. That is good. That's good progress. I was really concerned that on that second question we were going to get a whole lot of no's, because I know that they had extended the data submission for the 2016 data, and I was thinking, oh, I hope people aren't still just so wrapped up in that they're not thinking forward as to what they want to do this year. So that is great news for us. We want to make sure that you are sharing that information with your practice advisor from the PTN, so we can help you get the most out of those scores, and hopefully the rest of the information we present will help you. I also just wanted to point out, great that 58% of you participated in PQRS and looked at your QRUR reports and got a positive. The concerning one to me would be that 27% participated in PQRS but did not look at their QRUR report. It's really important that you be able to look at the data and understand where things maybe didn't line up the way that you thought that they were going to, or what you expected. So we'll talk a little bit about that and the importance of the QRUR. Under this system, the QRUR report won't, in its current format, won't continue, but it will be replaced by something similar, and all that data you just submitted for 2016 is still going to be reported out to you in a QRUR report in September of 2017. So it will give you another benchmark, right? Another data point that you can look at for comparison. Okay, so let's talk about the measures a little bit. One of the options available for measures are what are called the specialty measure sets. So yes, there's those 271 measures, and they're all over the place, but there is a way to look at it logically and try to narrow it down for what would be appropriate for your practice. So you see here just a screenshot of the QPP site, but I'm going to take you out to the actual QPP site. And this is what the QPP site looks like. At the top, so the address for the QPP website is qpp.cms.gov. You're going to see that at least 3 times in this presentation, so it will be available to you. If you haven't gone out here already, it is actually a very user-friendly site, so much easier to use than the regular CMS site. We're under the Explore Measures tab and under the Quality Measures part of that tab. And I just want to show you that this is the place that you can go to look at measures and get more information about measures. So if you haven't already selected, or if you've selected measures but you're really not sure if that's what you want to do, you can come out here. Hopefully your specialty is represented, and I do know not all of them are, and so I feel sorry that we're not all represented, but you know, a lot are, and more specialty societies are being approached regularly by CMS to help fill out this list. So if you aren't represented in your specialty, please talk to your specialty society about identifying specialty measure sets that would be helpful for you. So as an example, if I'm a radiation oncology practice, I can click there, and it will bring up all of the radiation oncology measures in their specialty measure set. Lucky them, they only have 4. If you have a specialty measure set that has less than 6 measures in it, and you report all of them, that's all you have to report. So radiation oncology, if they select this specialty measure set, they only have to report 4 measures and not 6. So that's a nice benefit. But that is not the case for all specialties. So if I went here and I picked cardiology, they have 20 measures. So if you're a cardiologist, don't feel like, oh my God, if I pick that set, I have to do 20. No, you only have to do 6. So you're going to do the smallest of 6 or the number that are in your measure set. So if you're cardiology, you can pick 6 measures from these 20 measures, and we know that they're going to be relatively appropriate to your practice. So that's what it looks like. You can also search by a specific thing. If I only wanted measures that have to do with diabetes, I could type in diabetes and hit search. Oh, and I have to clear it. I just did this before, and it messed up for me then too. There you go. There's your 11 diabetes measures. So there are 11 different measures you could pick from if you wanted to pick the most appropriate measure to your practice that has to do with managing diabetes. So that's just an example of the QPP site, and we'll refer back to it again. This is important. Are your measures meaningful to you and your patient population? CMS is going to continually tweak this program and push us towards clinical outcome measures that are appropriate to our patient populations and away from more general process measures. So it's, we recommend that it's better to start sooner than later in identifying the things that are truly important to your practice so that you're not getting into the game late once the benchmarks have risen so high that it's impossible if you're just starting out to hit them in the first year. We want to start now while those benchmarks are lower so that we're improving as the program is pushing more towards those outcome measures. So how does the scoring work exactly in 2017? Well, 3 points will be awarded for each of the 6 measures that you successfully submit. So minimum scores 3 points by submitting data. If a measure can't be reliably scored, and we'll talk about that in a minute, against a benchmark, 3 points is all you'll get. So if there's no benchmark for a measure that you pick, you might want to think about picking another measure to submit for right now, because the most you'll be able to get is 3 points if that's the one you report. If a measure can be reliably scored against a benchmark, then up from 3 to 10 points will be awarded based on your performance. There are separate benchmarks for the quality measures based on how you submit them. And all measure reporters, individuals and groups, are combined into one benchmark. So it's not like there's one benchmark for radiologists and one benchmark for endocrinologists and one benchmark for PCPs. Anybody who reports a specific measure, if it's A1C and poor control, if anybody reports that, it's dumped into the bucket from which the benchmarks are calculated. Registration requirements. So a lot of people ask this question, well, do I have to tell them what I'm going to submit? For the most part, no. The answer to that is normally no. But there are 2 situations where you have to register, and that's for groups. The first would be if you want to use the CMS web interface, you do have to register for GPRO, and you do that at the CMS site. We can provide more information for that later, but because right now only the 2016 information is posted out there, but so you can hang on for more details on how to do these registrations. And then if the group wants to report that CAPS for MIPS survey, so they want to use their CAPS data for one, that has to be registered too. So while we know that June 30th is the registration deadlines for these things, we have not been informed yet exactly where you're going to go to do that. Likely it'll be the same way it was in the past, but we will share that information as we get it. So let's talk about what I called reliable scoring, that phrase, reliable scoring. This is what reliable scoring means, and I want you to listen to this one carefully because it differs from maybe what you were used to under PQRS. First of all, to be reliably scored, a benchmark has to exist. So if you're picking measures and the measure doesn't have a benchmark, then you may want to pick another measure for reporting. You could still follow that other measure so that you're getting ready, but if a benchmark doesn't exist, you might want to think about that again. There's sufficient case volume. okay, greater than 20 cases for most measures. So that's a minimum. At a minimum, you need to be able to report the data on 20 cases. However, the other thing that goes to reliability is whether your data is considered complete. And the data for your practice will not be considered complete if you don't submit at least 50% of the possible data. So in other words, if 100 patients in your practice are subject to this measure, let's say it is diabetes and poor control, and 100 patients in your practice have diabetes, you've got to report data on 50 patients or 50%. So that 20 cases is a minimum. It's not all that you have to do. When you're looking at data completeness, if you were reporting through a registry or a QCDR or an EHR, it's all patients that are your denominator because you are keeping that information on all patients. If you are reporting your data through claims or the web interface or the CAP survey, it's only Medicare patients that would be involved. So in bold, again at the bottom, because this is a difference, the PQRS limitation of only reporting 20 cases via a registry for specialty measures no longer exists. So those of you who were simply abstracting 20 cases to get into your registry to submit under PQRS, that will not be an option. You will need to submit data on 50% of the possible patients that fall under that measure. So that's a big change. And another reason automating this through your EHR as best you can is going to be really important. As an example of data completeness, in endocrinology practice, this is the case, this sort of thing I gave. Choose to submit data for measure 0059 hemoglobin A1C poor control, and they're doing it by way of a registry. The practice has to report all payer data, so it's not just Medicare, it's all patients, on the greater of these two, either 20 cases or if 50% of eligible cases is a bigger number, that many cases have to be reported. And for this example, eligible cases is total all payer patients with the diabetes codes specific to this measure. So that is an important one, and you want to think about that as you're determining how you're going to collect, aggregate, and report your data. Okay, bonus points. 2 bonus points are awarded for each additional outcome or patient experience measure reported in addition to the one that's required. It's not 2 bonus points for each measure above the 6 measures that are required. It's 2 bonus points for each outcome or patient experience measure reported within your 6. So you still only get to report 6. Reporting more than 6 doesn't get you anywhere. It's the type of measure you're reporting that's going to give you the bonus point. You also get 1 bonus point if you pick an additional high priority measure in addition to the 1 outcome/high priority measure that's required. And you also get 1 bonus point if you submit your quality measures electronically end-to-end, in other words, through a registry or QCDR, EHR, or CMS web interface. In other words, not through claims. So you get a bonus point for that. To reiterate, there is no benefit to reporting more than 6 measures. Bonus points are for reporting outcome or high priority measures over and above the 1 that's required. And here is an example of what I'm talking about. If I report my 6 measures, including my 1 outcome measure and 5 process measures, I get no bonus points because all I reported was what I was required to. 6 measures, 1 of them being an outcome. If I report 6 measures, but 2 of them are outcome measures and 4 of them are process measures, I get 2 bonus points for this extra outcome measure. If I report 6 measures and 4 of them are outcome measures and 2 of them are process measures, I get 2 points for 3 additional outcome measures more than the 1 I needed, so I get 6 bonus points. But if I report 8 measures and still only 1 of them is an outcome measure and 7 are process, there's no bonus points for those 2 extra measures. If more than 6 measures are reported, the highest scoring measures will be used. However, we strongly recommend to reduce the potential for error in that selection on the back end at CMS. Select your own 6 measures on the front end and don't leave it to chance. And if you can pick more than 1 outcome measure, do it because that's going to give you your bonus points. Your maximum quality score is important to know. It's the maximum number of points available for the quality category, and it's based on your submission method and whether you had to have the readmission measure calculated by CMS. The readmission measure is not something you report, it's something that CMS calculates, and it only applies to groups with more than 15 eligible clinicians that have more than 200 cases. If you're smaller than that, it doesn't apply. So that means 60 points is the maximum for most practices, all submission methods except the CMS web interface. 60 points if that readmission measure doesn't apply to you, if you're not greater than 15 or 200 patients. It's 70 points if you have more than 15 clinicians and more than 200 patients. If you report through the CMS web interface, just because of the different way it's set up, 110 points is your total possible, 120 if the readmission measure applies to you. That's important because that's how you get your total score. Your total quality score is the points that you earn on your required 6 quality measures plus any bonus points, and you divide that by the maximum number of points you're eligible for. So basically the 60 or the 70 for most of our practices. So this is how it would work. If I have a 3-clinician practice and they decide they want to report as a group, with only 3 clinicians, the readmission measure doesn't apply. So 60 is the maximum number of points for this practice. The group submits their 6 measures and they do it for a full year. And the reported measures include 3 outcome measures and 3 process measures. And so their score would break down as follows. For their first outcome measure, let's say they scored 7 points. For the second outcome measure, they scored 8 points, and they get 2 bonus points because it's a second outcome measure, 1 more than they needed to. For outcome number 3, they also scored 8 points, and they get 2 bonus points because it's another one in addition to the one they were required to have. The rest of their measures are process measures, and they scored 10 points on each of those process measures. So their total points are 53, this sums to 53, plus 4 bonus points, or 57 total points. We divide those 57 points by the 60 maximum points they could achieve, because they're only a 3-clinician practice, so 60 is their max, and their quality score becomes 95. So that's their quality score for this year. This is a slide that you're going to see in every session going forward of this 3-part series, and we're going to build our MIPS score on this slide. So what we have so far is that example. On our example practice, for their 60% weighted quality score, they scored 95. So we multiply 95 by 60%, and it gives us 57. And that means our quality component score is 57. Each time we do one of these modules, next week or the following week, we will add scores for advancing care information and improvement activities, and then you'll be able to see what the final score is for this practice. It's just a coincidence that the weight this year is 60 and the total points available are 60. So it makes the math look like funny. But if the weight was 70% here, if quality was weighted at 70%, the way we would have done this is to take our 95 score, multiply it by 0.70, and the component score would be a little bit different. Right now, this year they happen to be the same. Okay. I've talked about the fact that there are different submission methods, and these are those submission methods. I wanted to lay them out there for everybody. If you are an individual, you have these 4 to pick from: a qualified clinical data registry, a qualified registry, an EHR, or claims. There are lists of these registries available at the QPP site, and I would recommend you go out and take a look at those if you're not using a registry. If you're a group, you can't submit through claims. You can do something called administrative claims, which is a little different, but you basically are limited to the web interfaces and the registry options. Again, that CAPS for MIPS counts as 1 patient experience measure, and you could do that one through CAPS for MIPS and then do 5 more through these methods, but that's the only one that's like that. Otherwise, everything has to be reported through that same method. All 6 have to be reported the same way. So these are some considerations I want you to think about as you move forward. The first thing is, what was your performance like on the measures for your last QRUR report? Here's an example of the table that tells us what that is. So for this particular practice, they scored 71.43% on this diabetes measure, 100% on screening for osteoporosis. This is the column you want to look at. What was your performance rate? And I ask a question at the bottom. If you were in college and would you wait till the end of the semester to check your grade when you know that your quiz scores account for 60% of your grade? Would you wait to check what those scores were? or would you monitor it in real time to make any changes that you could to improve it? Well, of course, you would monitor it in real time. So we don't want to wait for this QRUR report. It's an important tool, but we don't want to wait for it. We want to use it. We want to review the data. We want to make sure that it's accurate with what we're tracking on a real-time basis. But this can't be the only way that we're looking at our performance. It's a place to start. And why is this important? So let me get out here and open up this and show you something. This is that measure, okay? This is the benchmarking table that you can go and get out of the QPP website. And I'll show you in a second where you go get that. This is showing how this practice basically would have scored with that 71.3% that they had that year. If they reported through a registry, which is this line I have highlighted there, their 71.3% would put them well into the 10th decile. Okay, they would be in the top 10%. That would be a good measure to pick. They would score quite well on that. If they had only scored 48%, this would be telling them that they're falling in the top, within the not the bottom 70, but within 70% of the top. And while these deciles are not going to line up perfectly like with your scores, it doesn't mean if you fall into decile 7, you get 7 points. It's not going to line up that perfectly. The higher you are, the better you're going to score. And so looking at your QRUR report and comparing it against where would you have fallen is a really good way to determine what your score would have ended up being. So that's why we want you to look at that QRUR report and get an idea of where you were last year on your scores. If you answered that you have not accessed your QRUR report, this is an important slide for you. You need to know how to do that. And I'm pretty sure you're going to need to have the same kind of access no matter what this report looks like going forward. So this little flow chart that tells you how do you get your QRUR report. Well, the first thing you have to have is an EIDM account. If you don't have one or don't know if you have one, you need to come down this track. You need to go to this website and you need to establish one. I will warn you, you're going to need this information when you get there, and it is going to ask you questions similar to the kind of questions you get asked when you're opening a new credit card. You know, our records show that you may have opened a mortgage on this date with this bank. Pick the one. And they're trying to validate your identity by doing that. You only need to do this really for one person in your practice. Could be for multiple people. It depends on how you want this information shared. But someone in your practice really needs to be able to get these reports and look at them. If you already have an EIDM account, this is the path that you follow. You're basically going to go to portalcms.gov, select what you want, select what you want to look at, and then look at your reports. If you have a problem in this branch, this is where you call. The QualityNet Help Desk is where you're going to call. Okay, other considerations. I talked about this. How does your QRUR report compare to the published benchmarks? Look for your decile. The higher the decile, the more points you earn. Where do you find this? It is also at that QPP site. So we were there a few minutes ago. We were exploring measures before. Now we go to education and tools. We scroll down to near the bottom, and here is our quality benchmarks site. You click on that, it's going to download all the benchmark files for you. And what that's going to look like is this spreadsheet. So you can go download this yourself. You can look up your measures and see where you would fall based on your current performance. Another thing you want to watch for in there is topped out measures. You know, what's a topped out measure? This is the statistical definition of a topped out measure. It's statistically indistinguishable at the 75th and 90th percentiles and also have a truncated coefficient of variation of less than 0.10. Bottom line, they're the kinds of things that everybody is doing so well on, they're not going to be out there and available for much longer to report on. They also do not give you a great opportunity for scoring. You can see you need basically 100% unless you're reporting directly through your EHR. You need 100% to get full points on this one. you are going to get less than 10 points on this measure, even if you do it at 99.9%. We don't recommend that you pick topped-out measures, and we know that they are going to be phased out in the coming years. What data can your EHR provide you to concurrently monitor your performance? This is so critical. You need to talk to your EHR vendor about what you can get, what you can see concurrently. You need to be able to create and see a dashboard like this where you summarize your measures that you want to follow and how you are doing. If you can't do that, you're going to have trouble improving to the point of scoring well on these measures. We have available a system called the Outcome Sharing System that would help you if you do not have this analytic capability within your EHR, but it is something really important to know what your current EHR is able to do for you. We created a data assessment tool, and if you haven't seen or heard these questions from your practice advisor already, you will. This is included in the handout section of this seminar, so you can download it. It's a good exercise to go through to understand what your current EHR is capable of and where you might need additional help. And this is the second page of that assessment, and it's vitally important. It's really important that once you identify which measures you want to report, you plan to collect and report, that you understand where is this data collected, in exactly which field of the EHR needs to be completed. What needs to be in that field for it to count as a positive? How are you reporting it? Is it going straight from your EHR, or is it going via a registry? And if it's going via a registry, how's it getting there? Is the right data going to the right field? And if you're abstracting into that registry, are you filling in the right field on that registry? And then finally, what needs to be in that registry field for it to count? We talk to practices consistently who say, no, that data is wrong. I know we do that 100% of the time, only to find out that the registry or EHR is pulling it from a discrete data field, a checkbox, if you will, but the information is being recorded in a narrative note. So you need to understand how the data is being documented in your EHR in order for it to be reported correctly and in order for you to get credit for the work you are already doing. So the summary for selection tips: review your quality measure specs. Those are also available out at the CMS website. This is what they look like. It is a PDF file that tells you how do you count the denominator, how do you count the numerator, exactly how is it scored. It's important that you have that detail. They are also available at the same place where you go get your benchmarks. It's 2UP, measure specifications. Important to know that. Check your measure type to ensure you selected at least one high outcome and one high priority measure. Check your submission method to make sure you can submit every measure that you picked the same way. Review your numerator and denominator codes for each measure. They're going to find those in your measure specification sheet. Check to see if benchmarks are available for the measure. You have potential to earn more points if a benchmark exists. Check to see if the measures are topped out. If so, it's going to be difficult to earn quality points, and then compare your previous performance, your QRUR report, to the 2017 benchmarks. So in summary, MIPS-eligible clinicians have to select 6 quality measures, less if a specialty measure set that contains less than 6 is chosen. Measures can be reported in one of 4 ways: claims, EHR, registry, CMS web app, but not all measures can be reported by all methods. Measures can be reported for a full year, a partial year as a test to avoid penalty. Bonus potential increases as you report more data. Measures can be reported as a group or individually. You have to determine what works best for your practice by actually looking at the numbers. Measures chosen should reflect aspects of care important to your practice. We want this system to move to meaningful measures that truly reflect the care we provide for our patients. So we want to pick measures that are important to your practice. You should consider the published benchmarks as well as topped-out status to ensure your best potential for maximum points. You need to validate with your EHR or registry vendor exactly how each measure is collected and reported, and exactly how to document for positive credit. And finally, best practice is to monitor your performance on measures routinely, throughout the year to ensure your year-end reporting will be successful. Kaylin, we have a polling question.
Yeah, so our last polling question is, do you feel more prepared to select, monitor your 2017 MIPS quality measures? Yes, I feel confident. Yes, but I may have more questions, or no, and would need to discuss further with your practice advisor. Wow, everyone put in their answers pretty quickly. I'm going to go ahead and pause that. Go ahead and share those results. Cindy, we had 46 say yes, that they feel confident. 50% had said, I may have more questions, and 4% said they need to discuss further with their practice advisors.
Well, that sounds about right. I would imagine we all do have more questions. Honestly, I have more questions every day. I would like, though, to take some of your questions, and I know we're right up against the hour, but I'm willing to stay on if you have some questions and you want to continue. I would be happy to try to answer those. We broke this into 3 modules so that we could make sure we covered things thoroughly, and clearly we could use 6 modules probably to do it, but that's okay. We can answer whatever we can get to today. If you have a question we don't get to, please ask your practice advisor or put it in the chat box, and we will return, we will get those answers out to everyone in the end.
So Cindy, I had a couple questions come through during the presentation. One from Joyce Mackler. I'm going to go ahead and unmute Joyce's line and have her go ahead and speak to you directly. Joyce, your line is now unmuted. Joyce, are you still with us? Okay, it looked like she is no longer, she's muted. What I'll do is I'll move on. I have Hugh who has a question. I'll go ahead and unmute his line. Hugh,
no, I didn't have a question. I didn't have a question. I was just answering the request in the chat box to make sure we were listed as being in.
Oh, I apologize. Okay, that's fine.
Well, Hugh, we're really glad you joined us today. I hope that it was informative.
Absolutely. I had another question from Danielle Taylor. Unfortunately, Go ahead.
Kaylin, I was going to say, why don't you just read the questions, just because we're so up against the hour. If you have the question there, I'll be happy to answer it. Absolutely.
Okay, so moving on one of them was, we use a GI registry for reporting, GIQUIC. They said they have applied to be registry for MIPS, quality reporting, but they will not hear back if we're approved until May. So if approved, will we be reporting via registry those measures, and that will meet the quality reporting requirement?
Yeah.
And then the question responding right after that was, so individuals do not have to register a question.
Correct. So 2 things. Yes, if the GI registry does get the approval from CMS to be a MIPS registry, then you will be able to report through them. It won't be a problem. You will be able to report through them. If they don't get approved, you'll either need to select a different registry or work with your EHR vendor on registries that they may use, or you'd have to submit through claims. But if you're not already submitting through claims, you're not going to get a full year of data in. So, that's the drawback to that. I would say that most of the professional society registries that apply, they're well informed of what the requirements are, and getting approval is somewhat of a formality. But you do have to wait for that approval to come through, and then you would be able to report through that registry. Remember, reporting doesn't occur until the first quarter of next year. So you're collecting data now, you're monitoring data now, but you're not actually sending anything to CMS until the first quarter of next year. And so the question was, individuals don't have to register. That is correct. Individuals and groups don't have to register anywhere either, unless the way they're going to submit is through the CMS, like the GPro portal. So there's no registration required.
Another question, Cindy, was can individuals can't report CHAPS?
Correct.
Okay. And what is the difference between...
Well, I'm going to go back on that, and let me investigate that a little further, because a practice that is only one provider who does participate in CAPS, I'm not sure why they wouldn't be able to report. So let me take that one back to technical assistance and ask about that. Individual CAPS. Okay.
And what is the difference between a registry and a qualified data registry? Does what you said about both registry apply earlier apply to both?
Okay, everything that I said does apply to both. I knew someone would ask this, and I thought this morning, oh, I should really brush up on the differences. They are subtle. It's two different designations that CMS gives as to what a qualified clinical data registry is, and then what just a registry is. I wish I had looked it up so that I could give that to you. Bottom line is, whichever way you report, the registry requirements are exactly the same for both of them. And that's another thing that I'll have to send you some follow-up information on. QCDR versus a regular registry.
And I think the last question...
I think I was going to say there's capabilities are different between the two of them, but on the front end, right? To be qualified as a qualified clinical data registry versus a registry on the front end, there's more capability to the clinical data registry. On the reporting end, I just don't think there's any difference. So go ahead, Kaylin.
The last question that I have in the queue was, does a participation in the practice transformation count as an activity only if you are attesting at a test pace, or for all testing paces?
For all. And we'll talk more about that when we do the improvement activities module. This is a great lead-in. When we do the improvement activities module next week, we will talk more about how that works. But yes, participating with the PTN counts as an activity, whether you are doing test pace, full year, or partial year.
And actually, Cindy, we had one more question come through. If I choose to partial pace, or contribute to a partial pace 90-day report, is there 3 particular timeline I would have to collect data? For example, March, June, October through December.
It has to be 90 consecutive days. That's the rule. It'll have to be 90 consecutive days. So technically, you would have to you would have to start by October 1st, right? Collecting your data, October 1st, 2017, because you wouldn't be able to get 90 consecutive days collected by the end of the year if you didn't. So it just has to be 90 consecutive days. Now, it's not really imagined that you're going to report March, April, and May and then not send in any more data, right? The 90 days kind of works, I think in practicality will work this way. Here's my 6 measures that I want to use. I'm going to start tracking how we're doing on them. I'm not really liking how we did on them in the first quarter. Let's make some changes. Okay, in the second quarter we look a little better, but still it's not great. By the third quarter of the year, we're looking pretty good on those. You might want to only start when you submit your data. You might only want to start with your third quarter reporting. And instead of 90 days, it would be 120, right? You'd report 2 quarters worth of data. So the 90-day partial year is basically giving you time through this year to concurrently monitor your performance and improve before you get to the fourth quarter, and you have to do it by the fourth quarter data, right, to have partial year. You have to report the whole fourth quarter if you want to get your 90 days in. So it's kind of imagined to be that way. It's not really meant to say, oh, pick 90 days in the middle of the year and just report those 90 days.
Thank you, Cindy. I think that concludes the questions that have popped up in the queue, and I don't have anyone raising their hand. I want to remind everyone I'm sorry, go ahead.
I was just going to say a couple things. If you did not download the handout already, Kaylin, we will be sending the handout out to everybody.
Correct. I was just about to say that, remind everyone that this is just part one of a three-part series, and ask everyone to register for part 2 and 3. I will also be sending out the slide deck to all attendees from today, as well as uploading this recording to our YouTube channel once it is rendered.
And then I would just like to add one other thing. I put the slide up. I really do want to give a shout out to Quality Insights, who has been instrumental in providing technical assistance and working collaboratively with us in producing these kind of events. Also, the link for the CMS One Stop Shop, the QPP website, is listed here. It's pretty easy, and we hope that you use it. And of course, the last thing in the handout is going to be all of the practice advisors and Health Vision's PTN staff who you can contact for more assistance if you need it. So thanks, Kaylin, for your help today.
Of course. Thank you, Cindy. I'm going to leave this last slide up for just a minute, and then we'll end the presentation for today. Thank you, everyone, for joining us.